I literally called this in the introduction when you voted on it, posterior open bite hell, because I'm not just going to show you like, hey guys, here's this little posterior open bite. I'm coming at this with like, here's a crappy posterior open bite that's coming because we do a bad job of expanding the arch without the right attachments. We didn't do enough buccal root torque. So literally our first molars have hanging palatal cusps. If we need to expand the arch, we really should be having horizontal attachments or optimized expansion attachments. Or if not that, optimized retention attachments. But we need to have the attachments on there to help support the movement so that the actual root is moving. This is the patient. She comes into our practice and she has a really restricted arch, right? The lateral's blocked out as well. Partially erupted in the second premolar spot. When we look at her Ceph, she's got a pretty normal facial balance. There's nothing significant going on. We're not going to go super in depth with all the growth and development. If you want to know more about that, you can take the mixed dentition course. But looking at her C-spine, she still has a very horizontal C-spine here. There's no curvature on it. So she's not quite at her growth. Even though she's 12, it's not showing that she's about to hit the end of her growth spurt. So we know that utilizing class 2 elastics in her case should be fine. When we look at her pan, again, we see the one primary tooth still hanging on. So that's going to be the upper second primary molar. But for the most part here, what do we need to do? Well, we need to develop the arch. We need to fix the crowding. We need to ensure that she's going to be finishing with a proper overjet and overbite. And because this is a growing patient, whenever we have a growing patient, we need to finish that patient in class 1 occlusion. Well, let me rephrase this. The goal is to correct the patient to class 1 occlusion with the molars and the canines, with the midlines on, with the ideal overjet and the ideal overbite. The saying is treat adults realistically, treat growing patients idealistically. Now, the reality is this, is that I do not always finish all of my growing patients in a perfect class 1 occlusion because they don't always wear their elastics. They don't always listen to the instructions and they get burnt out just like adults do. And so for me to say that we always finish our cases class 1 molar and canine, that's not actually correct. We always attempt to finish our patients class 1 molar canine, midlines on, proper overjet, proper overbite. But it doesn't always happen that way. So please know that. Okay, so this is the situation. Now, her ClinCheck is actually interesting here because this case was actually accepted on December 30th, 2020. Now, you're going to see here that you're going to say, wait a minute, you just said you finished this case today. I will come to that because this patient is not in active treatment from December 30th, 2020 until today. Yes, that is 3 years or 4 years ago, but you're going to see some of the strategies for settling posterior open bites and how we utilize the aligners to make ourselves more efficient for the settling because you don't have to go directly into viveras when you finish the movements. But what you see here is that this patient's biting in a class 2 molar. They're also biting, I mean, they don't have their canine in yet, but they'd be biting in class 2 canines on both sides as well. It's fairly significant. Now, what's interesting is because this case was from December 30th, I actually will ask my Invisalign reps how they're doing when it comes to their case numbers. And so with this case, I was actually not ready to accept it. But because I wanted to get it in for the fourth quarter for my rep to try and get as many cases through, I actually started this case with much less on it than what I normally would. So what you're going to see here, and this is the cool thing about treating growing patients, is that the movements express fairly consistently. So even though normally nowadays I'd be having attachments on my posterior teeth, right? I have attachments on my first molars for the expansion. I'd have more attachments on the lower, on the first molars to help with the deep bite intrusion. Even though this is way less than what I would normally have, what you're going to see is that the movements actually express pretty decently because that is the one benefit here of dealing with a growing patient is that their movements are more consistent because their bone has less ends. But the key things I want you to take away from here would be this, is that if we have a deep bite with a more significant curve of speed, well, what do we need to have at a bare minimum for this case? Well, at a bare minimum, we need to have attachments on our premolar teeth that are horizontal attachments where the tray can lock in underneath the gingival aspect of that attachment, or an optimized an optimized retention attachment or deep bite attachment to again help the tray lock in. Because what we need is we need the tray to snap in underneath that attachment and then push down on the anterior teeth. Right? When we look at the ClinCheck, what you see, and I like looking at the superimposition tool, because the superimposition tool will often show us where we start. And so you can see that we're intruding the anterior teeth, obviously. And so if we're pushing down on those anterior teeth, one of the biggest mistakes that happens is that doctors do not have attachments on their posterior teeth. Now, again, if I was actually treating this case from scratch, I would put another horizontal attachment on one of my posterior teeth. Or I'd put another optimized deep bite attachment or retention attachment on my posterior teeth. So how would you do that? Well, I'm going to pull up just a sample case here that I can make a modification on. Is right here on the top of our screen. If we hit modify plan, we can actually jump in and we can put the attachments on ourselves. So if I want to have attachments that go on all of my premolars and molars, I literally click and I drag and I drop them onto the teeth. I can move them to wherever I want them to go. I can pull them out thicker. I can change wherever they are on the teeth. So you have control over this. It's extremely easy to do, and you can do it both with the conventional attachments, which are the attachments here, the square blocky ones, like you see, or we can do it with the optimized attachments. So the optimized attachments are the ones that are custom shape created by Align. They're Align's proprietary attachments. And that's the attachment that's being used on this side. This is an optimized retention attachment. So you can place either of these, but the key component here is that you need to have attachments on those lower premolars and molars to help support the intrusion of the anterior teeth. So that's the key component, and that's what we do have, at least on some of the teeth. Now again, I would place them on the posterior teeth as well because it's going to give us more support when it comes to actually locking the tray into place. Now, another thing is this patient right now, we're focused in her case, she's very concerned initially about the aesthetic aspect of things. And so what we actually chose to do is we placed attachments on the lingual surface. Now, would I do this again? Would I place them on the lingual? Well, I think you certainly could. You're going to see here that things actually express really well. And she doesn't eat with her aligners in. Because she's only 12 or 13, we actually have her take out her aligners when she's eating. Even if she bites down on these attachments, I don't really care all that much. Because when we do braces, we often have it where patients have essentially bite turbos on their posterior teeth that prop the bite open. So if she's biting a little bit on an anterior attachments, do I care that much? No. But in this case here, I said, yes, let's go ahead and plan this so that we place some attachments on the lingual because this was important to her. This is actually the daughter of one of our staff. But in reality, it would be fine to obviously place things on the buccal. The challenge is sometimes if the teeth are hidden behind the anterior teeth, it's hard to place an attachment in certain areas. So you don't want to place an attachment that's physically impossible to place. So placing it on the lingual does give us more access because this whole surface is available, whereas there is some overlap between the central and the lateral. But yes, we place the attachment on the lingual. We focus on arch development and expansion. Now, one thing that you're going to notice in the plan is whenever I have blocked out teeth, and you'll see this on the next case as well, one of the things that I find so crucially important when moving teeth past one another, and this is doubly important when it comes to moving teeth past each other when they're adult teeth, is ensuring that there is space for the teeth to move past one another. Again, I repeat, one of the most important things is space, because you need three things for teeth to move into the proper position. You guys know if you've ever heard me speak in person before, what are they? There's three of them. Force. You need force on a tooth to make it move. That's logical. You need space and you need time. If you don't have force, space, and time, your movement's not going to be successful. And so we have the force, that's going to be the tray pushing against the teeth. We have time because we have 30 trays here or whatever. And so we need space. We need to make sure we don't bind on the neighboring tooth, which so frequently happens. So the instructions I would have to the technician here would be to create some space around these teeth as they move past each other. Let's actually see what I asked them for. I asked for 0 collision tolerance. See on treatment plan number 2, I specifically asked. So I often ask here, do not allow collisions during movement. So that means that the teeth should not bounce into one another. This is a global thing that I ask for on every single case. Do not allow the teeth to hit and collide. So do not allow collisions on teeth during movements. Sometimes my plans don't show all of the previous text instructions on plan number 2. I must have asked for it on plan number 2, and because this is a demo case, it doesn't show it. But the main point to take away here is just that what you would ask the technician for, you could say something along the lines like this. Let's just say this was the case. You could say to them, create 0.1 millimeter of space between the, I'll use the Canadian numbers here, but the 1, 1 and 2, 1, 2 as the tooth moves into the arch. Something as simple as that. Okay, so that's all you need to say. And then what I like to say too is do not close the space. Or do not close the space until the tooth is in the arch. Or in its most buccal position. Here's the thing. There are so many different ways that you could phrase this to a technician so they would understand what you're asking for, right? Please essentially create space around that tooth as it moves to make it more consistent. And again, if we didn't create this space, would this plan not work? Well, no, this plan probably would work. It's just if you were to run this situation 10 times over, it might work in 7 cases without creating the space, but I want it to work 10 out of 10 times. I don't want it to ever not work, right? So we ensure that there's space between the teeth as they move past each other when there's really hard movements like blocked out teeth. So this is what we're planning and designing is essentially arch development and expansion. Lateral incisors create space, move buccally. Now, one of the things that's going to cause us problems with this plan is, I mentioned it before, look at how I'm not putting anything on my terminal teeth. I'm not putting any attachments whatsoever. Well, what ends up happening if you try to expand and arch develop without having attachments on your posterior teeth, a frequent thing that's going to happen is the teeth are going to tip. The palatal cusp is going to hit more prominently than the buccal aspect of that tooth. Right? And even in this case, the other thing I didn't do well is that I didn't overdo the torque. So what we really should be doing, again, this is just a demo model case of a different situation. If I want to go ahead and expand and develop the arch, the first thing we should be doing is ensuring we actually place on attachments that help lock the tray in place to support the movements. The second thing that we would do is we overdo the buccal root torque. So if we hover this section right here, you can see that this says root torque on your 3D controls. So when you're in the modifications, you click on this, and now you can actually click on the arrow, and you're moving the buccal root, or the root, towards the buccal. You're creating buccal root torque, right? If we were actually to get rid of the bottom arch, and let's even just bring this tooth down so we can see it a bit more, right? As you add buccal root torque onto this tooth, what's going to happen is this is the initial position shown. Well, that palatal cusp, and actually let's even just get rid of this tooth out of the way. You get out of the way too. Okay, I just want to look at this tooth. So if this is the original position here, we need to go ahead and create a lot of buccal root movement here. So the way that you consistently do this is that you have an attachment that's there, that's a horizontal attachment, or an optimized expansion attachment that allows you to lock the tray in place And you need to intrude this palatal cusp, so to speak. And in some cases, you could also look at it as extruding the buccal cusp. And so you're intruding the palatal cusp, you're extruding the buccal cusp. And so by overdoing some of this movement, it means that even if all of this movement doesn't fully express, as long as you get a portion of it, it's going to help improve the situation. And again, I'm here to show you this case, warts and all, that this palatal cusp was already hanging. Right? Look at that palatal cusp. It's literally looking us in the face compared to the buccal cusp. And yet, when I plan this out, I don't really overdo the buccal root torque, and I don't have an attachment on the tooth. So in two circumstances here, I'm creating myself a lot more problems by not having the right attachment design and not having the right biomechanical movements. Again, look at this side. You literally see the palatal cusp hanging there. So what do you think is going to happen? The palatal cusp is going to hang. And this holds true with adult cases as well. Now, here's the thing is that there are circumstances where you will eventually expand and hit the cortical plate and you can't go any further. That's just the reality of arch development is you only have the skeletal structure available to you. So if you keep expanding and you hit the cortical plate, you can't just magically move the teeth through the cortical plate to do more expansion. Eventually, you reach the limit of what can be physiologically accomplished based on the width of their palate. Okay, so let's go ahead and take a look at what we actually accomplish in this ClinCheck. So this is the initial position, and this is where we're at after our first series of trays. That is pretty sweet, guys. Like, we didn't have the right attachments on a number of our teeth. We did have the right movements to move our lateral incisors past the blocked out lateral incisors past our central, so that's helpful. But we could have done a lot better with our design. In terms of the deep bite, there's been intrusion of the anteriors, and we're much more flat with our posteriors. So that's good. Now, you start to see right from the very beginning, though, we are showing a posterior open bite. So that posterior open bite is in part because we're hitting prematurely on certain cusps. So if you actually look here, we're actually hitting prematurely right now on our premolar, that upper right first premolar with our lower right first premolar. So the first thing I want you guys to do when you have a posterior open bite is to evaluate, why do I have a posterior open bite? What are they hitting? If they're hitting with the cusp on cusp, like we see here, well then what do we need to do to close this posterior open bite? And I want you to think about that. They're hitting prematurely, and they're prematurely hitting maybe only on one specific area. So if they're hitting just prematurely on one cusp, like you see here, well, theoretically, if you were to take a burr right now and you literally just chopped off this entire cusp, right, the 1-4, the upper right first premolar, and the lower right first premolar, if you just chopped off their cusps, well, the posterior open bite would close. And then they'd probably start hitting on this palatal cusp. And then maybe they'd hit on the palatal cusp with the premolar. So am I worried right now that I'm biting in a posterior open bite because I have a premature contact? No, I'm not. Right, and on the other side here, you can see expansion has happened. And what's happening in reality right now is that this patient is biting in a functional shift. Because we're developing her maxillary arch, and because of how constricted it was before, as we develop her arch, well, she's kind of hitting in a strange position. She doesn't really know where she's hitting. And so I'm not too worried right now about all the details of finishing this case, because what I always recommend when you're taking on these harder cases is to approach it from the perspective of golf. Right? Our first shot was the drive. Right? If you guys saw this case right now and I said, treat this, you'd potentially say, like, wow, that's a lot going on, Stephen. I don't know that I want to take that on. But now if I told you, treat this, a lot of you would say, oh, that's not too bad. There's a developed arch. The canine's now in. I don't need to worry about that. That's more straightforward. Right? If I go to the next round you're going to see more and more. I'll just jump ahead. And I said, treat this. You'd probably say like, wow, that looks really easy, right? And as we keep going through each batch and working on these details, you don't need to be worried on your second set or your first set about the minute details because we have a lot of different strategies in our toolkit to help close posterior open bites. That it's the equivalent of this. If you are golfing and you're on a par 5, are you worried about reading your putt? Are you looking at the green saying like, oh, if I'm here, I need to putt it slightly downhill and it's going to go around. I need to watch the break and I need to hit it this hard? No, you're not. You don't worry about that. Your first worry and your first concern is just to have a really good drive. And then hopefully you're on the fairway. And then your next concern is to focus on your next shot, which is now maybe you're going to use an iron and you're going to use a 5-iron and hit it really far. And then your next shot, you're going to be focusing on chipping it on the green. And then you're focused on the actual putt. So at this point, to be quite blunt and honest with you guys, I'm not focusing on the posterior open bite in any significant extent, except for, am I prematurely hitting something that kind of needs to move out of the way or that other teeth need to move? That's the key thing. That's the important thing at this point in time. It is not focusing on all of the details and trying to get my bite completely dialed in. Because again, to be honest with you here, on this initial plan right now, do I look at the occlusion tools? Do I click on these occlusal contacts on treatment plan number 1 and go all the way through and look at it and say, ooh, where are all my green dots? How's it really looking? No, I don't. I don't really care all that much because I am much more focused right now on the big picture. Because part of the reason that this patient is biting in an open bite is because they're class 2. Right? We look at their premolars. Well, yeah, they're biting in a class 2, and we need more class 2 correction. So if we're going to go ahead and bring down this canine, level the bite a little bit, and then if there's going to be a growth change that happens from this patient using class 2 elastics, which is shown on your ClinCheck as what's called a bite jump, well, the bite jump is actually happening from the use of elastics. Right? She's using elastics in this second plan now from her lower first molar to her upper canine in a class 2 orientation. So what is it doing? Well, it's pulling back her maxillary arch and it's pulling forward her mandibular arch because she is a growing patient. Right? So the maxillary arch, so this is how the elastics hook on, first of all. So we're going to have a button here, a button here. We glue them to the teeth. They're super easy to use. So then she hooks on her elastics. Right? And all you ever have to do to try to figure out which direction are your elastics pulling, I mean, literally just draw on your plan an arrow towards the other teeth of where the elastic is stretching. This is the direction that things are trying to move. So the maxillary arch is moving back and the mandibular arch is trying to move forward. It's really straightforward. Again, I know that many of you right now don't treat mixed dentition or growing patients or teen patients or anything like that. And this isn't mixed, this is teen. I want you to understand the biomechanical principles, and I want you to hopefully strive to one day treat cases like this because it's not super complicated. Literally, this case is as simple as putting an elastic or a band that she hooks on from her top canine to her lower first molar. That's it. She changes the elastics out 5 to 7 times a day, and that is what accomplishes the changes because she's a growing patient. And in our different courses that you can take in diagnosis, development, and treatment planning, and in our mixed dentition courses, and if you're a member of Clearly Select, I teach all of this more in depth so that you have those insights to understand how do elastics work and function, how do we treat growing patients. So again, please don't get scared off by the fact that I'm showing you some elastics right now. What I want you to take into consideration is the fact that the posterior open bite here is because something is hitting prematurely. And so we need to get the other somethings, aka the other teeth, to either extrude down, which is what we're showing here, they're extruding together, or to physically move out of the way through the use of something like the elastics, helping the mandibular arch, promoting as much growth as possible, and actually slowing down and restricting growth of the maxillary arch. Again, this seems complicated. It is not complicated. This is actually super straightforward because We know she's growing because she's only 12 years old or 13 years old. And we know it from looking at her C-spine, which again, I'm not going into all that right now, but we know there's still growth available for this patient. So if you were just treating this as an adult situation, can you change the bite by jumping forward like this? This bite jump, is it realistic and possible? The answer to that is no. It is absolutely not realistic and it is not possible. The reason why it is not realistic and it is not possible is because, well, as it's showing this jump, that's simulating growth and growth modification. But if you have a 35-year-old adult, and you'll see this on the next case with our growing or our non-growing 16-year-old, we treat him like an adult. He's not growing, he's not changing his positions, and so we don't expect that the bite is going to necessarily change. Notice here how we have the hanging palatal cusp. I talked about it before, how we literally planned this because we did a poor job of understanding the expansion that we needed. And again, I'm not going to blame it all on Millen and trying to get this case in before New Year's. So it would go in through for that quarter. But obviously, we always try to get cases through too if we are trying to get them through for our own advantage status. But this is my error. This is my problem. This is my fault. Like I should have done a better job of making sure there was another attachment on that tooth because we have the hanging palatal cusp. So we have two things going on. Again, I literally called this in the introduction when you voted on it, posterior open bite hell. Because I'm not just going to show you like, hey guys, here's this little posterior open bite. I'm coming at this with like, here's a crappy posterior open bite that's coming because we do a bad job of expanding the arch without the right attachments. We didn't do enough buccal root torque. So literally our first molars have hanging palatal cusps. Beyond that, because this patient is occluding prematurely, they're only hitting against one tooth, which we're going to address by correcting the class 2, right? And I'll go ahead and show you some other things that add to this class 2 posterior open bite. But again, at tray number 1 on this side, it's not quite as bad, but on the other side, it's much worse because of that premature contact. So what do we do again? Well, we focus on our class 2 correction, utilizing the elastics. Seen this already. And what do we expect to see? Well, if she's not wearing her elastics at all, what I would expect to see is that her bite will look exactly like this at the end of this round, where now she will have contact with all the rest of these teeth. But what she won't have is she won't have nice intercuspated teeth. But if she wears her elastics well, then we should see an improvement to that. Let's just go ahead and take a look at her upper first molars now, right? We had these hanging palatal cusps. So on this plan, do we do better with our plan? Well, not tremendously, because yes, we have a little bit of buccal root torque, so we see a little bit less of that hanging palatal cusp. But in reality, I should have actually intruded this way more because this cusp is still hanging significantly at the end of this round of trays. And this side is better. So this side started hanging, right? We can see it. And then by the end, we've actually added in some buccal root torque. So that's much better. But in reality, again, because this premolar has the same hanging palatal cusp, I should have really put an attachment on this one. A nice horizontal attachment with a good crisp edge like you see here. The darker shaded area on that attachment on the gingival side is really what we need. And I didn't. Now you might be saying to me, Stephen, I just want to get one thing straight. When I look at your ClinCheck, I see there's a lot of attachments. My answer to you is yeah, totally there is, because if we need to expand the arch, we really should be having horizontal attachments or optimized expansion attachments. Or if not that, optimized retention attachments. But we need to have the attachments on there to help support the movement so that the actual root is moving. On our lowers, if we want to fix a deep bite, we really need to have enough attachments on there to help support the intrusion of that deep bite. If we don't have enough attachments to support the intrusion, then it's not going to fully express and you won't flatten your curve of speed, like you see here. So we need posterior attachments for the expansion on the upper. On the lower, we need it for deep bite correction. On the upper laterals, well, there's such hard teeth to get to track that we need attachments for them just for basic tracking purposes. Now, fortunately, her lateral incisors are quite large, so we actually have a lot easier of a time than somebody with really small lateral incisors. But if we want to extrude these teeth, which we do, then we need to have attachments on them. Whether they're going to be conventional attachments on the lingual, whether it's going to be optimized extrusion attachments on the buccal. So in this case here, we said, yeah, let's use some optimized extrusion attachments to help with that movement. Right, I actually took off the attachments from the lingual at this point in time because now she was more comfortable with attachments on the buccal. And so this is essentially our plan. And again, it makes sense why we need to have enough attachments, because if that tooth requires a significant amount of movement, whether it's extrusion, whether it's torque, whether it's tip, if it's any root movement, in almost all cases except for intrusion, it needs an attachment on it. So what do we accomplish? So on our second round of trays, before we went into this ClinCheck, this is what it looked like. You can see the premature contact. And she's propped open. You can see the other side is open, but it's maybe not quite as bad. So after we go ahead and we work on the anterior posterior correction with the class 2 elastics, well, hey, look, we actually had a really good class 2 correction. Because she wore the elastics well, and she's a growing patient, now our canine is actually biting pretty much perfectly intercuspated, or interdigitated, I should say, between the lower canine and the lower first premolar. And again, this is the easiest things in the world. It always blows my mind that dentists are so scared of gluing a button to the tooth with some cement. Super easy to do. And literally giving the patient some rubber bands. And I'm going to show you if I have time. The last case, the class 3 correction, one, we'll hopefully have a couple minutes to talk about in the questions time period, but just how basic it is that if you are worried, and you'll actually see it later here, I think even in this case, that we overdo things with the elastics. Well, what do? Is you can just either use elastics in the opposite direction, or you just stop using the elastics. But at this time point now, because we got the premature contact out of position, well, our open bite just got a lot better. It looks way better. But what do you see? What's that going on in the posterior? That is a heavy palatal cusp. Right, in the posterior here, we're still propped open. Right here from hitting prematurely on that cusp. And if we go to our next ClinCheck, this is treatment plan number 1, what do you see? Hitting that cusp, because the cusp is still hanging down because we didn't do a good job with our buccal root torque. We didn't overdo it. On the other side, and not to say that it's not just overdoing it, this side here is better. And we actually did overdo that one more, but we're still hitting prematurely on that palatal cusp as well. So let's go back to our photos. So you can see that the midlines were, on our last ClinCheck, quite off. Right? The lower was deviated fairly significantly towards the right side. Well, as soon as we use the class 2 elastics, which makes sense, as you use these elastics, remember I had this drawing where I said our lower would come forward and our upper would go back? Well, yeah, that's exactly what happened. Our lower came forward and our overjet is less significant. Our teeth are intercuspated or interdigitated better. On this side, we didn't use the class 2 elastic. I know that's a common question that people will ask is, do you ever use elastics unilaterally? And I do. So you don't necessarily need to worry about, in my opinion, I mean, there's different thoughts of this, but can you use class 2 elastics on just one side? Yeah, we did. Now, there's some schools of thought that say it could cause TMD, but in my hands, I use class 2 elastics unilaterally fairly frequently, and I don't have issues with TMD problems. So I'm not saying you have to do that in your practice, but just in my hands, I don't use bilateral class 2 elastics in every case. Okay, let's keep this moving. So our midlines are slightly off. Again, because she's growing, we're going to try to treat her idealistically instead of just saying, well, yeah, this is good enough. Like, let's just settle the bite and call it a day. No, we're still wanting to work on things because we know that there's still some improvements that can be made. So when we look at it now, let's go ahead and take a look at our ClinCheck. So we see that we're propped open. On the other side, we see that we're propped open. We can see now that actually on our left side, we are a little class 2 as well. So we've actually added some class 2 elastics now on her left. Not for TMD issues, but because you can see that she's slightly off when it comes to her midlines. So we actually now want the lower to come slightly forward on her left side. So what are we going to do? Well, we can use class 2 elastics because we can change the position of her jaw because she's growing. On this side here, we want some elastics just for nighttime. Again, not to say we don't ever use elastics just at nighttime, but we're going to utilize these elastics mostly just at nighttime. And on her left side, she's going to use them more full time. So see now how we have the attachments that are going on our upper second molars, and we're focusing now on a lot more buccal root torque. We're trying to get the contacts that are hitting prematurely, like the palatal cusp. We're trying to actually almost intrude that, right? And we're bringing down the buccal cusp. That's what we're trying to do. But again, the real world doesn't always care what we're trying to do. Sometimes we think that we're doing a great job with it, but the body doesn't behave the way you want it to. And that's why this is called posterior open bite hell. Because we're trying to bring these teeth down. There's nothing crazy going on with this clean check. So maybe nighttime elastics on our right, left side, full-time elastics on our left. Okay, so that's the plan. So what do we accomplish? Well, at the end of this round, I'll jump to our photos. We took off a number of the attachments before taking this photo. But you can see here that when we look at her position of her teeth as they relate in the class 1, class 2, class 3, well, we're pretty close to class 1 on her canines. Her midlines are just slightly off. And she's in class 1 now on her other side. So she's biting in a nice class 1 on both sides. The arch development looks great. On her lower, the arch development also looks really good. So the arches themselves are really good. It's just now a matter of getting the teeth to actually settle together. That's the key component. Now, I'm going to show you where things don't work. Again, I told you I'm going to go ahead and give you this straight. I'm going to show you where things work well. I'm going to show you where things don't work well. On this plan, the mistake that I made is that often if you have a true posterior open bite, the teeth will settle. Now, why do we know that? Well, we know that teeth will settle on their own if you have a true posterior open bite because those teeth will extrude. They will super erupt until they have contact. Think about a situation where a patient loses a lower first molar and their upper first molar, it's going to extrude until it hits something, right? Until it has contact. And so that often messes up our implant site. So we know that that's a problem. But in this case, we know it actually helps us. But what I fail to recognize on this plan is the fact that it's not just a true posterior open bite. Instead, what's happening here is that the patient is still propped open on the palatal cusp. And so, again, it's not a true open bite. Instead, it's a hanging palatal cusp open bite. Right? If this was a true posterior open bite, all you need to do is literally you could walk away, you could leave, and these teeth would settle on their own. You could come back in 2 years and 5 years and 20 years. You come back in the future, those teeth will super erupt until they hit something, unless the tongue is tongue thrusting between those teeth or those teeth are ankylosed. Right? With my own case, I distalized my second molar. I didn't even need Invisalign. I just wanted to do it so I could explain these concepts and show that we don't need to be so worried about posterior open bites because we have lots of options on them. But in my own case, what I did is I literally intruded my second molar and left it there. I intruded like 3 millimeters, and then I just cut the trays and I let that tooth super erupt back into a full occlusion. And it's not something that's super like doesn't take a significant time period in most cases if it's a true posterior open bite. So that's what I want you to know and understand is just that there's a lot of options and solutions that we have here to trying to correct this. Now, in this case, again, the first thing we could have done better was having more buccal root torque before we tried to expand these teeth and bring them together. But in this case, then, well, what are we going to do? So we're hitting heavy on the palatal cusps. So I'm going to go back to our clean check. We've taken off the attachments because what I will often do now to help settle posterior open bites is, and again, the clarification I want to make for you here is that this is not as successful if it's a palatal hanging cusp, if it's a true open bite. Like this, let me see here, is any of this true? No, none of this is actually a true open bite, right? She's actually hitting prematurely on the palatal cusp on all these teeth. So what I'm showing you here was doomed to fail from the start because she's in contact. But what I will often do if there is a true posterior open bite is I will actually give them trays that they're only going to be wearing for 16 to 20 hours a day with no attachments, no bumps, no buttons, nothing, no elastics, just literally just the trays. And the idea here is that you allow these posterior teeth to settle, to come together. In this case here, I'm showing more of a intrusion of getting the cusps out of the way to let the bite settle. In some cases, it'll actually show the teeth moving together to settle. But all we're trying to do is get those palatal cusps out of the way, or to let the teeth come together to actually come down tight. So if I was doing this again, would I move right into this strategy? Well, no, because hitting heavy on that palatal cusp isn't going to solve the problem. But if this was any other type of posterior open bite, then definitely you could just give this time and it will settle more and more. But I don't. Instead, I do this with no attachments. And what you're going to see then is not a lot. Right? She comes back. And what I'm doing as well, just so you understand, is that for the first round of these trays, we're starting off with the patient wearing them full time. So we have batch 1, 2, 3. It's a hard case. There's lots going on. So for the first 18 months, we're having them wear them full time. Then what I do with all of my cases is my patients wear their retainers for 6 months, what I call full time. But full time actually means 18 to 20 hours a day. We call it 16 to 20 hours a day, right? The reason why I plan this out is because I want to have the trays off the teeth more so there's more time for things to settle. Because if the plastic is always between your teeth, it doesn't always allow them to come together and to settle. So my patients, though, wear trays essentially either all the time, right? Call it 20 hours a day or 18 hours a day. But I don't have them just go to nighttime as soon as they finish. And the reason why that is because I don't want these patients um, to have relapse and to shift. I had a patient today with a consult who said that she finished doing orthodontic treatment about 3 years ago, and she was told pretty much go right to your retainers from month number 2. It was full time for 2 months and then right to nighttime. And her teeth shifted and moved. Now, she also wasn't obviously compliant with the retainers because if she was compliant and came in, although she did say that she had went in multiple times to tell them that her teeth didn't feel good and that they were trying to shift, and they said just go nighttime. But the reality is that if you are just going nighttime too soon, in my hands at least, I have lots of situations where my cases still shift and move. So no matter what, in our practice, we tell patients, look, here's the reality. This case is going to take you 2 years or maybe even 2.5 years for a case like this one. And you're going to have 6 months of wearing your retainers full time. That's just the reality of complicated and challenging cases because it takes time. But what happens then is this patient comes in then after wearing these temporary retainers and her bite is not settled. We're still propped open. So what are we going to do? Well, what we're going to do in this case is we could go ahead and plan to use some buttons and elastics. And this is why I think that it's important just to understand that utilizing buttons and elastics is important, whether you're talking about teen cases or adult cases, because it is the end of the line for some of these posterior open bite cases. So let me jump ahead here to show you what we do. Because what we can do is we can actually place buttons onto the teeth and have this patient wear elastics to help pull the teeth together. This is why I'm never really worried about posterior open bites, because at the end of the day, all we really have to do to close a posterior open bite, for the most part, at the end of the day, the final solution to all of this is just to say, you know what? We're going to place some buttons and elastics, and we're going to help extrude these teeth down into a full contact. That is the solution if you can't get anything else to work. So what do we do? Well, we place buttons and elastics on these back teeth. And the way that she's going to wear them, we actually add elastics. So I'll show you this first. So first of all, we had them only on certain teeth, and this one actually broke off at this appointment. So we actually had it on more teeth. But ultimately where we get to is the point where you can literally put elastics and buttons on the majority of their back teeth. Anything that's currently open, and you can see from here where it's open to where it is here and then here, that we're running elastics vertically on any posterior teeth that are open, right? We're open in the posterior here. It's this one here. So we put on buttons and elastics, we run those elastics vertically, we help pull those teeth together. I mean, I'm kind of giving you the answer to the question already because you can literally see in the posterior here that all of these teeth are nice and tight, right? The posterior open bite has mostly closed. So we pull these teeth tight so that from where it was before to where it is now, those teeth are pulled together. Now, what do I actually do on my ClinCheck plans in order to allow that? Well, one of the options is you can literally do something like this, where you can just ask the technicians to virtually remove the posterior teeth. Now, you don't have to do this. You could literally just get a full aligner, like get them to give you like a full aligner like this, and then just go ahead and cut distal to the canines or distal to the premolars. And then you can just vertically run those elastics. But you could also go ahead and ask them, please virtually remove all of the posterior teeth. Right? I don't want those back teeth in place because those back teeth, I don't want plastic between them. Right? The plastic between them isn't going to help us here. If we're kind of hitting like this, heavy on the palatal cusp, I'm trying to pull the buccal cusp down so that it's going to occlude better. So that's what we plan. Generally speaking, the thing that you have to know about this is that you do not want to do this for a really long period of time. Like before, when we're looking at this situation and I'm trying to settle this just with my Invisalign trays, right, that are simply extruding these teeth and trying to settle the bite and whatnot, this is maybe 6 months because we're stabilizing the teeth at the same time. We're just trying to do this in the most appointment efficient way possible, right? You could also go ahead and cut your aligners in the back if you didn't prop open on your palatal cusp. But because we're propped open, no matter what we did, this wasn't going to work. We needed to use vertical elastics here. But you could go ahead and prop things open, or you could go ahead, sorry, and cut the aligners there. But the key thing here is that utilizing the elastics is a fast thing. Like this isn't going to take a long period of time because what you don't want to do here is you don't want to go ahead and run these vertical elastics and end up over extruding all these teeth and creating an anterior open bite. So I would recommend that you should be checking like the time frame from point 1 to point 2 here is actually only like 2 weeks, right? It's fast. It's like 2 weeks between when you're bringing them in. So every 2 weeks you're bringing them in and checking because this is meant to be very, very quick. So how do you run the elastics? Like for those who utilize elastics right now, how would you actually do this? And again, you can do this in an adult case, you could do this in a growing case. If we had planned this case better, I will just tell you this, we wouldn't need to use these elastics. But I'm not here to show you everything that we do perfectly well. I'm here to show you the things that we need to sometimes jump into solving the problem, working our way through the mud. So in this situation here, we can use a triangular elastic to help pull down the premolars and pull up that lower premolar. And in the posterior, we can use a box elastic. So the box elastic, we would be using a size of 1/4 4 ounce. For the premolars, we'd be looking at 3/16 4 ounce. Now, I'm not going to go into elastics too much right now because I teach about it quite a bit to our doctors in Clearly Select, as well as I have it in different courses. But if you would like to know more about elastics, I'd love to teach you guys that. They're really not hard. They're not challenging to do. You could literally just go ahead and do this. You could just write down these numbers, 3/16 4 ounce, whenever you're using triangular on the back, and 1/4 4 ounce in the anterior, and that's or in the sorry for a box elastic in the posterior, and that's really all you need to know. But I do want to teach you more than just that too. So um, I don't have time right now. Like the goal with the plans and showing you all this is to kind of show you what we're doing. But if you want to know more of the how, then that's where a lot of the content comes in with clearly aligned courses. So you can see now that our teeth are biting in much better occlusion, right? When you compare where we're at after using the vertical elastics, we have contact now, and the buckles of these teeth have been pulled down. But there's still something going on. When we look at her plan, when you actually see it here, even though we've pulled down the palatal, or sorry, the buccal cusp, it's still slightly open, even though we have contact and it's looking way better. Because when you look at it from this angle here, this is essentially showing the same angle as what's in the photos. When you look at it from this side, it looks great. Everything's perfect. Let's call it a day. But if you actually look from this angle, it looks more like there's still a little bit of open bite. And so my goal is, again, to try and treat all these patients to as close to perfection as we can. And so here's the amazing thing again. If you've ordered 5-year comprehensive, you have as many trays as you need. So rather than jumping into the stiff Viveras, which ironically would probably do what I'm about to show you here too. But if you instead want to go ahead and plan something like this, what you can do is you can actually go here and extrude these teeth into a tighter contact. And in reality, actually, I'm actually here to start with, right? You can actually allow these teeth. We start off with just 4 trays of trying to allow some settling and extrusion. And then I realized, okay, I'm going to get a few more. So what we actually just did is we said, you know what, Brooklyn, we're going to go ahead and put you into some aligners that are going to help bring these teeth into a stronger occlusion. And we're just going to give you essentially 1 year's worth of retainers, quote unquote. Now, these retainers are just Invisalign aligners because there's still some more settling I want to accomplish. Because again, if you look at it from here, you're like, great, those teeth are much heavier in contact. But I really want to bring those teeth into further contact. And so rather than getting her Viveras right away, why don't I just go ahead? And she's only been wearing these trays after her buttons and elastics just at nighttime. So why don't I just go ahead and get her trays that she wears at nighttime, and we give her 1 year's worth of trays, of Invisalign trays that she just wears at nighttime, and look at what happens. And where we're open on these premolars, it settles. And same thing on the other side. Where we're a little bit open, it settles. So the takeaway that I want you to have from this is if you correct the palatal or the buccal root torque, even if your occlusion isn't perfectly socked in, you can either get trays and get enough of them to last this patient for a period of time to allow the masticatory features, the function of the teeth, to allow the settling of those teeth if it's just slightly off. But if you have a really significant posterior open bite where you're hitting the palatal cusp, right, and it's propped open, you need to go ahead and correct that torque. Now, whether that's through utilizing your elastics and your buttons, or whether it's planning in more torque earlier in your plan in order to ensure that movement happen, that's the key to ensuring that your back teeth are all going to be touching, like you see here. So in this situation, the patient's teeth are biting in nice occlusion. She's biting in a perfect class 1. Class 1. She's biting in with her midlines perfectly on. Her overjet and overbite are in the ideal position. So I hope that makes sense. I know there's a lot of information in that. And again, my goal in presenting this to you is just to show you the real world. I don't want to just show you a case where I'm like, here's what I planned and here's where it worked perfectly. I needed no problem solving. I needed no solutions. No, literally in this case, I have situations where I have made errors. I also show how easily some of these movements can happen if you plan the right things. Like even though I didn't plan everything properly, we still had good intrusion of the lower incisors. We still worked on our expansion. It's just we didn't get our buccal root torque. We still had our lateral incisors move buccally into the proper positions, right? And if we look again at, I'll just go to her photos here, the arch development from where she first started to where we're at the end of treatment on our lower arch. And again, you've seen the side views, the front views, and everything else. So that's the takeaway I want you to have from this, right? And I think a lot of the times why speakers don't always show all the problems that they go through is because you're putting yourself out there, right? There's 199 of you right now who are looking at my cases. And I mean, that's what my goal is, not to be your guru and to tell you, here's a formula and you do it the exact same way every single time. My goal is to give you the knowledge and insights to recognize that there's solutions to these problems and that maybe you would approach this differently. Maybe you would have cut the trays. Maybe you would have used elastics from earlier. Maybe you would have changed out the attachments and gone with optimized extrusion attachments. That's all okay. It's totally fine if you want to treat it a different way. I'm just trying to show you, again, the different scenarios of where we treated something and how we had to work our way out of some of the problems that are in front of us. The beauty of this, again, is that when you are treating and you're placing an implant or you're pulling a tooth, you can't say to a patient, hey, you know what, we got half your tooth out, we're going to finish the other half later. No, but when you are dealing with orthodontics, you don't need to have everything figured out from the start. And if you have a supportive community where you can work through these problems with doctors, who know what they're doing, then it's okay if you don't feel like you know how to putt on this par five, because that's the whole vision and goal of our Clearly Select group, is that we are there to support you through these situations, through the challenging times, to give you the insights and to give you the tools so that you can say, you know what, elastics and buttons, that's easy. I have a patient who has a posterior open bite and it's hanging on the palatal cusp. I know what I can do to get this out of problems. And there's other ways you could address this. We could have constricted the arch slightly. That would have also worked. You don't have to use the buttons and elastics. There's other ways we might have treated this in other situations.